to the point of acquisition costs and the costs of drugs and why these people have, or these entities have come out with these various tools, and Ted can check me on this, isn't it true that in 2014, the rate of rise of drug costs was about 8 or 9%? And back in 2015 and all the years before that, it actually tracked with the overall medical cost rise in the 3 to 4% range. And the 2014 spike really had to do with more people being covered and a novel therapy set in hepatitis C. And so we have these tools all coming out that Bruce is asking us to critique as kind of a knee jerk for a one-year aberration that doesn't actually create, it's not a trend.
Well, I will say that actually if you look at the component costs of care, so think about the pie chart and divvy that up in terms of drug and hospitalization and surgery and radiation and radiology, a lot of things that Alan has mentioned, that actually the largest growing component, according to the Milliman study that they just released, is from 2004 to 2014. That component, both on the commercial side as well as the Medicare side, is the #1 growing component. And it's growing, and it's grown over that period by over 300%, 400% on that side, on the commercial side of it. But why it's grown is because it's grown by the biologics. The biologics, which were a very small sliver, now incorporate a lot bigger piece of that. So you have that piece of it. And the interesting thing is overall, so if you look at cancer costs on the commercial side or the Medicare side from 2004 to 2014, and you compare the rate of increase up against, sore throats and everything else, all patients, commercial and Medicare, according to that study, they're essentially the same. Everybody thinks that cancer is growing by this huge amount. Now, it doesn't jive because I said, wait a minute, the drug costs are growing at a big component, as is radiation. But hospitalizations, surgery, and some other things have decreased during that time period or grown at a less of a rate. So that's why overall, when we say, oh, cancer care costs are doubling or tripling, that may be on the drug side, but specifically because of new therapies. And it doesn't let you guys off the hook because there's still a pricing issue. But the fact of the matter is that overall, the rise on both the Medicare and the commercial population is identical. And this is sort of a landmark study that surprises people.
And let's not forget that the drug cost trend is mitigated by the introduction of generics into the marketplace, especially my Tovaclone, which used to be $3 a pill and now it's 30 cents a pill, which makes me very happy.
I'm not totally going to blow that out of water because I was going to say one more thing about the evidence blocks. Directionally, it's the right thing in terms of the usability of it and getting to something that I think could facilitate, and that's what it is designed to do, that conversation between the patient and provider. I still think it doesn't get all the way there because of the input problem, and that's not something the NCCN could charge themselves with solving. I will say from an affordability perspective, it does try to capture other things besides drug. The problem with it is it's sort of asking a committee to sort of hypothesize about how affordable do you think this is from your perspective. So there's not really, it doesn't have the same sort of level of evidence and systematic approach that the other segments of the evidence block have when it comes to consistency of evidence and quality of evidence and safety and efficacy. But it's a start, but it definitely from an affordability perspective, it's more looking at it from that societal, what is the cost to the system? And again, from a patient perspective, just because you think it's a 5, it may be very affordable to me. So I think probably of all of those things, that's the one that has the least utility right now from a patient perspective.